Good afternoon, everyone, and thank you for joining us today. I'm Ellen Lautenberg, a board member at the Institute, and I've had the privilege of being involved with environmental health at Mount Sinai for about 15 years. When I first started, the primary focus was on how the environment shapes children's health. Since then, it has grown into a world-leading institute with more than 100 scientists and clinicians focused on how the environment impacts human health across the full lifespan. As you probably noticed, many diseases are rising at an alarming rate, and this rise can't be attributed to genetics alone. From autism, asthma, infertility, certain cancers, and neurodegenerative conditions like Alzheimer's disease, it's the environment that we know is the missing piece of the puzzle. From the air we breathe, the food we eat, to the social stressors in our lives, our environments are truly dynamic. To understand its dynamic nature, we need new methodologies and technologies to be able to assess the cumulative effects of multiple exposures. And it's the concept of understanding many exposures that is the key. Through new technologies like sensors, wearables, and satellites, there's a vast amount of environmental data available today. And it is the relatively new field of exposomics that will give it meaning so we can make better health decisions for ourselves and our families. Today, you will hear from two scientists from Mount Sinai advancing this field who will discuss their work on climate and health. It is Climate Week, after all, in New York, and this is perhaps the greatest public health challenge before us. We aim to keep the webinar to a total of 45 minutes. So at about 1:30, we will begin the Q&A portion. Please use the Q&A function, and we will get to as many questions as we can at that time. Dr. Itai Kloog is an exposure scientist and geoinformatics researcher working at the intersection of environmental and public health. He specializes in developing advanced exposure models to understand the health impacts of air pollution and temperature extremes. His work has led to significant advances in the accuracy of environmental exposure assessments, making it possible to analyze health risks with greater precision, including looking back in time to understand past exposures. Dr. Kloog will be joined by Dr. Perry Sheffield, who will reflect on how these advances in exposomics are informing clinical care and community interventions. Dr. Sheffield is a pediatrician and researcher specializing in children's environmental health with a focus on the impacts of climate change as a leader in national and statewide environmental health programs. She has advanced policies and research that protect vulnerable populations, particularly children, from climate-related health risks. Now I'd like to invite Dr. Kloog to get started.
Thank you so much. Share my screen. Nope. Can you see my screen, everybody?
Yes.
Okay, thank you again. So I was asked to give a kind of a general audience talk about our research regarding mapping our environment using new AI and machine learning tools for bettering our health. And I'll start with a fun fact. Climate change is indeed real, even though it's not always a consensus. And human-made climate change is leading to adverse health effects. And there's an overwhelming scientific consensus that this is true. I would say 99% of the scientific population are in consensus on this. I know I don't have to explain this to people in this audience, but I want to kind of briefly have an overview of understanding climate change and its adverse health effects. So we know that the average surface air temperature has increased 1.8 Celsius over the last century. Greenhouse gases like carbon dioxide trap heat. Carbon dioxide levels are higher than they have been at any point in the last 3.6 million years, and this changing climate is leading to dramatic effects on human health. We also know that this affects human health in significant ways. We know that temperature extremes are severely affecting our health, more heat-related deaths and medical visits for cardiovascular, kidney, and respiratory disorders. We have increasing floods that leads to increasing drowning deaths and higher exposures to mold and waterborne diseases. Increased wildfires resulting in poor air quality, which increases respiratory and cardiovascular issues like asthma and COPD. And of course, air pollution. We have a higher exposure to particulate matter and ozone, which increases in turn hospitalization and deaths for respiratory diseases like asthma. We also have longer growing season, which causes an increase in allergens and pollens, which in turn can translate to more airborne pollen and increased allergy rates. And of course, mental health and stress-related disorders. Climate-related disasters such as floods and hurricanes, alongside wildfire, can lead to higher rates of adverse health effects and poor mental health. Who are the people that are at risk? We know that the susceptible populations include children, socially vulnerable populations such as minorities, older adults, people with chronic medical conditions, people with disabilities, workers, and of course, pregnant, breastfeeding, and postpartum women. So this is a brief introduction, and let's talk about how we kind of look at climate change in terms of health research. So climate change, as we've discussed, affects air quality, and certain air pollutants can affect climate change as well. For example, hot sunny days associated with a warming climate can increase ground level ozone in some areas. And the WHO has estimated that fine particulate matter air pollution, what we call PM2.5, contributes to approximately 2 million premature deaths per year, ranking it as the 13th leading cause of mortality worldwide. This increase in our exposure to air pollution also obviously increases our health risk, and we have published multiple papers on the topic, including the association with higher levels of air pollution with hospital admissions, mortality, reduced birth weights, cardiovascular disease, respiratory disease, and heart attacks. Now, what we're seeing in recent years is just as this current body of epidemiology studies looking at these adverse health risk effects with air pollution, we're also now trying to see and address the health impacts of exposure to extreme air temperature events. These changes that we see in climate will lead to warmer temperatures and more extreme health events, such as extreme heat or extreme cold, which are associated with increased morbidity and mortality, specifically as we discussed in sensitive populations. This increase happens not only during heat waves, which is important to say, but also during less extreme events. If you have an overall warmer or hotter summer, this could also lead to very adverse health effects. Now, why are we interested in quantifying or looking at precise exposure measurements? And the reason for that is for epidemiology studies on health effects really relies on exposure data, whether, how long are you exposed, what levels are your exposures are. And a big issue in environmental epidemiology is exposure bias or exposure measurement error. The reason that this happens is that it's unfeasible to hand every person a monitor or to stick a monitor in every single person's house. We have, huge areas such as continents. We have, huge populations, so we use models. Now, models, even though they tend to use large geographical areas such as state or nations as the unit of analysis, can severely bias our health effects when you assign airness exposures. And I'll give an example. This is the Los Angeles area. And you see these kind of white rectangles which denote EPA air monitoring stations. Now, people that live very close to monitoring stations will indeed get the correct exposures. But let's say you live far away from a monitor station, right? And you run a simple analysis of an interpolation. You kind of approximate, the levels of exposure between these different monitors, which is a simplified way that we use to calculate or assign exposure. You can be living very far away from a monitor or close to a monitor that has very low levels, but you are living on a 5 or 6 lane highway, and thus your exposure levels are very high compared to the levels that you would get from a monitor. So we need to address that, and as exposure scientists, we're looking at reducing this error. And in addition, most of the studies that we conduct are focused on urban areas because, first of all, most of the monitors are mainly placed there. That's natural because the bulk of the population is concentrated there, and thus people living in rural areas do not get correct exposure estimates. And finally, there is an increasing recognition that the risk estimation must recognize the people that are exposed to multiple risk factors simultaneously. So we're looking at multiple pollutant as opposed to a single pollutant, which gives us a more holistic view or holistic reconstruction of the true environment that you live in and what exposures you're exposed throughout your life course. So to address these limitations, we started at Mount Sinai to apply new approaches using machine learning and AI, incorporating hybrid methods, bringing in satellites and other technologies such as wearables and drones to really try to reconstruct our exposures holistically, as stated, going back 25 years. So we can, in essence, and I'll show you how we do this, take your place of residence and reconstruct on a daily level all the different exposures, whether it's air pollution or temperature, that you have been exposed for the last 25 years. In essence, building you a profile or a passport of all the exposures you've been exposed to in the last quarter century. And how do we do this? So we apply new methods. We call them hybrid methods, and I'll discuss first our air pollution methodology. This is using specific satellites, in this case, MODIS, the Moderate Resolution Imaging Spectroradiometer. And we have a long-standing collaborations with the PIs, the leading groups at NASA. There's different algorithms that NASA provides. We're using something that's called an algorithm that's called MAIAC, which is a hybrid of the different algorithms that accounts for both very bright surfaces, very dark surfaces, such as shorelines and the ocean, and also provides very high resolution products. And the products that we use is called AOD, aerosol optical depth, or aerosol optical thickness at times, which measures the light extinction by aerosol scattering and its absorption in the atmospheric column. In essence, what it's doing is it's giving us an approximation of how many particles are and the concentration within the column of air. The problem with that is that we're interested in what people actually breathe. So we can't use the product as is. We have to calibrate that with additional spatial and temporal variables. So we add to our models between 50 to 150 different predictors, which could be land use data, transportation data, atmospheric chemistry, population data, and so on, layering that within a model. And then we developed in recent years different machine learning algorithms and methods to try to give us the best resulting model that will predict with the highest accuracy. So we use different imputation techniques. We use random forest in this case. We try to fill in the gaps with missing satellite data. Satellite data isn't continuous. For example, you can have clouds, you can have dust storms, you can have a rainy day, and thus we'll have gaps in the data. So we developed an algorithm that allows us to expand and impute continuous surfaces of the satellite data. We then can take this satellite data and then calibrate that with stations coming from the EPA, in this case, PM2.5 or air pollution stations. And we have different machine learning algorithms, whether it's gradient boosting or random forest, or even our own developed algorithms such as GMRF, Gaussian Markov Random Fields, which is an algorithm that we developed to produce better predictions in areas which are rural, as I said, are far away from the monitors, which are centered in urban areas. We also developed different algorithms to do model ensembling because each one of these machine learning algorithms have their own biases. So by ensembling these methods, allowing the predictions to move freely over space and time, we can get an overall better predictor. Okay, so this is kind of a short introduction to the methodology. Of course, I'll be happy to answer any questions that people may have. But the end result is a very robust modeling framework that we've been running in different countries across the world, including the US, which has resulted in many publications and use in a lot of environmental epidemiology study. Here's an example of our generated prediction. In this case, we're looking at PM2.5 concentrations in 1 by 1 kilometer grid cells. You're looking at Boston for 2003. You can see the variation of the predictions between the urban downtown core, the rural areas. You can even see how we managed to capture exposures or air pollution levels from highways and major roads. And this is a second stage of the model where we downscale our model to higher resolutions, in this case, 200 meters. And you can see again, kind of the variability across Boston. You can even see that I plotted point source emission data. So these are factories and industry areas that generate higher exposures. And you can see that we can also capture these exposures as well. In terms of prediction accuracy, this is less interesting for this kind of general audience, but our models perform very well, which is almost close to ground truth data. So in essence, to simplify things, you can imagine that we're expanding from 50 monitors across the Northeast, 5,000 virtual monitors or even more. And one thing to note is that satellites are global. We don't only cover North America. I mean, the satellites don't only cover North America. So we can expand our approach globally. But unfortunately, it's not that simple. It's not a one-size-fits-all approach because each region presents different unique challenges. Some regions have issues, with dust storms across the Mediterranean. Some regions are mountainous. Some regions are very humid. So we have to adapt our models per region to really account for the specificities of each region. So for example, in Mexico, we have to deal with, higher level of humidity and a very low kind of planetary boundary layer, a lot of strong wind regimes. In Israel, we have issues with very bright surfaces and, as I said, sandstorms. So the models really have to be adjusted continuously. These are some of the examples of the models that we run in different regions of the world. We have models that we run in Europe and in India and in Mexico and other regions quite successfully. So air pollution is a component of climate change, and obviously temperature is a significant component as well. So, why do we actually need to model temperatures? Can't we just use monitoring stations from EPA or the general weather services? The problem is that we really, again, rely on these spatial temporally resolved air pollution measurements when we do robust epidemiological models. If we don't have enough spatial variation, as I've shown, this leads to exposure assessment error and thus exposure bias, which could lead to false conclusions from our epidemiological models. So we know that weather stations are rarely dense enough, specifically in urban and rural areas. And other reanalysis data, such as these models we keep hearing about that do global analysis, are not high enough in terms of resolution and efficiency to really rely on for high resolution studies. So what we did is we're working towards predicting temperature data and doing that even diurnally to have hourly data as opposed to the 24-hour means of air pollution using, again, satellite data and machine learning approaches. We take data from weather station observations, reanalysis data, remote sensing, and we run some of our machine learning algorithms that I've mentioned before to produce, first of all, land surface temperature surfaces, again, kind of imputing from the satellite, and then going deeper in terms of resolution. So spatially going down to 200 meters and temporally predicting hourly temperature data. And this is an example just visually showing the imputation stage where we take the satellite data, run our machine learning algorithms, and are able to reconstruct fully the land surface temperature from satellite data. And then we can take that data and run our machine learning models to predict hourly air temperature data across a specific region. In this case, I'm showing an example from Israel, where we're able to predict hourly air temperature data with very high statistical performance. And these are more examples. This is an example that we do run these models in Israel. This is an example closer to us, looking at New York. You can even see the difference within a city. So this is our mean predictions from 2011. And you can see the spatial gradient between the area that you can all recognize as Central Park, where you can see a few degrees centigrade, which is a few degrees centigrade cooler than the urban downtown core. Now, this differences is accentuated if we have extreme heat events, where you can have 6 to 7 to even 8 degree centigrade differences between people living, around Central Park and people living in other areas of the city. And again, model performance is excellent, even when we kind of look at different performance metrics and looking between seasonal performance and so on. Model performance is always excellent. This is an example of a work done in France by one of my former PhD students in EU. And looking at modeling France, what we did in France was introduce another dynamic stage where we know that in urban areas the spatial and temporal variability of temperature is much higher. We have issues with heat island effect and so on. So we go deeper dynamically into the city, into high resolution, and you can see the difference in terms of variability and performance when we go higher in terms of the spatial resolution. Now I'm going to mention a few other kind of models that we do very briefly, because I know time is getting short. So we don't only model climate and air pollution. There's other environmental exposures that we focus on, because again, we want to give an holistic view of all the exposures that you're exposed with throughout the life course. This is the concept of the exposome that was mentioned, looking at the totality of exposures throughout the life course. So we also look at noise modeling. We have different models using land use regression methodologies and actually field campaigns. Unfortunately, we can't use satellites to model noise. So we have to actually go into the field and measure noise over years and then calibrate that with additional land use parameters to allow us to extend our models to different regions. And this is an example of a noise exposure model that we've been doing. We're also very interested in light at night and circadian disruption. So light pollution is defined as the alteration of natural light levels in the outdoor environment owing to artificial light due to man-made sources of light. And this is a map that we created in the lab for 1997. You can see the differences between the kind of, urbanized regions of the world and other kind of more rural areas. This is a map that we created in 1997. This is a map that we created for 3 million years ago. This is a joke, of course. But this would be what it looked like, because our algorithms can clear away areas of fires and so on. So this is only the light that is anthropogenic, which is man-made light. So in a way, we have similar methodologies that I've shown before to incorporate satellite data from different satellites and using different spatial or geospatial algorithms to, again, kind of reconstruct your light at night exposures across your place of residence. And I'll end with a few slides on kind of how we use this in environmental exposure analysis and epidemiological studies. Even though we love modeling and that's our main focus, we understand that the big kind of end point of this is actually using this in health analysis. So this is an example of a study that we published a few years ago, looking at short-term effects of particle exposures on hospital admissions in the Mid-Atlantic states. Even though many studies report significant associations between air pollution and hospital admissions, these studies, as I said, often are very limited because they rely on a very limited number of monitors, which can introduce exposure error and exclude a lot of the population. So I want to show you an example of how using our models, you can really incorporate the entire population and make your results much more generalizable. This is a map of the Northeast, and I put in the monitoring stations that we have across the Northeast, and I put a buffer of 30 kilometers around them. Now, even 30 kilometers is quite coarse, and that's already introducing a lot of exposure bias. But people have been using or assigning exposure from these monitors for people living very far away from them. By using a model that's spatial-temporally resolved, you can actually account for the entire population and assign robust air pollution and climate exposures to the entire population and include them in the study. So we did that, and we did a case crossover analysis, which is a type of a very clever analysis comparing or matching by admission type and comparing the day of the week, the month, and the year as hazard periods. So each person is his own control. I won't go into the details, but what we found is increased admissions for all respiratory, CVD, stroke, COPD, and IHD admissions for every unit increased in air pollution exposures. And in a similar way, we also perform studies looking at the association between air temperature, birth weight, and gestational age. In this example, Massachusetts, we looked at evaluating the relationship between birth weight and temperature during pregnancy in Massachusetts for a 9-year period, where we estimate the average exposure to temperature during various prenatal exposure periods from date of birth to the full pregnancy of each mother. Again, we can cover the entire population because we have these, very spatial temporally resolved models. And we found a consistent effect of increased temperature and birth weight for infants who were born full term after adjusting for other potential risk factors, such as previous and current mother health conditions, socioeconomic factors, and physical environment risk factors. We also found that gestational age was decreased by increasing temperature during pregnancy, with gestational age failing by about 1 day for each degree increase in mean pregnancy temperature. We have a very similar study in Israel looking at ambient air temperature for our models, low birth weight, and small for gestational age in term neonates in southern Israel. And again, we found very consistent results that lower pregnancy temperature may increase the risk of term low birth weight and small for gestational age newborns, but also that higher pregnancy temperature may decrease the risk of HGA in singleton term infants. To summarize, we have shown consistent effects of increased temperature and birth weight for infants who were born full term after adjusting for other potential risk factors, and that gestational age was decreased by increasing temperature during pregnancy, about 1 day for each 1 degree decrease. And we'll finally end with the fact that we're also making accessible a lot of these novel exposure data for free as part of the Mount Sinai Greener platform, which is the Geospatial Reproducible Environmental Exposure National Exposome Research. It's a long name, but we had ChatGPT to help us get to this acronym. And the goal of the Greener platform is to develop and provide to the general audience and the scientific population a dynamic and continuously updated environmental exposure platform for state-of-the-art national environmental exposure data, so people will be able to log in, choose the area of residence, and kind of get information on their exposures. It's currently in development, and hopefully within a year or so, we will be make all these different types of data available for the general population. So thank you, and I'll move the conversation over to Perry.
Thanks so much, Itai. I'm happy to be here and offering some reflections on your presentation, and also happy for the audience to hear sort of two different angles of work that's happening in our institute. You, Itai, as the exposure scientist and geoinformatics specialist, and me with a background in pediatrics, doing environmental epidemiology, but also co-directing our clinical networks. We have a regional pediatric environmental health unit and a statewide New York children's environmental health network. So as many of you in the audience might have just experienced, that was mega amounts of data that Itai uses. It's phenomenal. And it's also connected to one of the fundamental challenges that's facing clinical care, which is how to funnel and filter so much information to be able to direct patient care and for communication with patients and their families. So I think the tools that Itai described are really ushering in a new era of access to this more localized, hyper-localized information, as you heard, about exposures, but also with the AI capabilities, there's also possibilities for sort of rapid interpretation of that information, what it means, what we can do about it, help get the right information to the right people at the right time, right? So you heard Itai talk about vulnerable populations, but as the medical students that I was teaching yesterday said, we'll all be vulnerable at some point. It's based on just our age alone, but there's many other factors. So it's not really an if, it's when. And even when we're not in one of those vulnerable categories, we all are affected. Our health is affected by the environments that we're in, and that's increasingly changing under a changing climate. So I ask myself, what would be my dream for when I take my child to the doctor, how they would be able to guide me regarding exposures. And I would love to hear her inquire and be able to advise about my home environment, my neighborhood, and the changing context of those environments. I want the doctor that sees my child to be a champion for healthy homes. And I want her to be able to help me make it a reality for my family. So let's imagine together a scenario where every clinician has access to an AI machine learning enabled application. Maybe it's the Greener platform 3.0 version. Let's call it Healthy Places, the Healthy Places app. It could consider in the environment in the near real time where someone lives, where they work, where they go to school. And so I imagine this conversation happening. The doctor says to the patient, my Healthy Places assistant tells me that there's a lot of new construction in an area where you live. How is that for you? Are you noticing a lot of noise, a lot of dust? And let's make sure that you have options to be able to close your windows, turn on HEPA filters. Hey, we have a prescription program where we can write you a prescription for a new HEPA filter. You can go get that, or you can get that delivered to you. We also can assign you up for assistance with your energy bill if that's a stretch for your budget, right? Or maybe following a hurricane, a doctor is able to say to a patient, my Healthy Places app says that your building has a higher number of maintenance complaints lately. Or I see you live near a contaminated area that was recently flooded. Are you experiencing any leaks? Have you smelled? Are you seeing mold? Did any of the flood waters from that contaminated area come into your house or your apartment? Our clinic is connected to the housing department for this local city, and I can help you make sure that that's being addressed safely and soon. Or if you're not comfortable with a government agency working with you, we have community partners that also work on housing issues, and we can connect you to those. So AI can't build those relationships. They can't build the partnerships, but it could help interpret information and help guide clinicians on messaging. Our pediatric environmental health team here in the Institute within our Department of Environmental Medicine and Climate Science has a program called Prescriptions for Prevention, and we're building environmental health screening programs across the state through our work with NICE-CHECK, or the New York State Children's Environmental Health Centers. We are teaching doctors what to ask, how to counsel, and how to help families access healthier options and resources. So I think that these AI and machine learning tools can ultimately help expand that work and really transform clinical medicine. So we're going to pivot now to the Q&A portion of our session, and I'm going to pass it back to Ellen to start us off.
Great. That was fascinating. Both Dr. Kloog and Dr. Sheffield, thank you so much for your overview and on this very complex topic, and for your insights on how it applies to clinical care. So in order to just kick off the Q&A, I have one question for Dr. Kloog, and then we'll be taking questions from our audience. So my question is, what other types of environmental exposures besides the air pollution and temperature extremes can be similarly reconstructed into the past?
Right, thank you. So as I mentioned, we're trying to, expand our exposures as much as we can to every possible exposure. Obviously, it's very difficult because not all of them we can use these hybrid methodologies. So obviously, we talked about particulate matter, air pollution, but we have, gaseous air pollutants such as NO2 and ozone, obviously temperature and humidity, greenness, how green the area you live in is, how many walkable areas you have, accessibility measures, how much access you have to healthy food or kind of, healthcare. We're also looking at applying, a lot of the new technologies such as wearables to get at what happens inside your house. All our exposure models are kind of, ambient or outdoor place of residence. We're also trying to use new technologies such as new sensors to build devices that will also give us information on what happens indoors. So we're trying to expand as much as we can to paint a holistic view, a complete view of all the external exposures that we are exposed to.
Great. And Dr. Sheffield, do you have any questions that are coming through?
Yeah, I do. This is another one. Let's see, Itai. How do you typically gather the location of the participants to determine the pollution exposures? And specifically, are you able to use wearable devices to gather location of where the people are?
Right. So it's a very kind of charged questions because we have issues of privacy. So traditionally, we do this through collaborations with researchers, epidemiologists, and clinicians, and whether it's through a cohort or EHR data, we go through IRB, we go through different privacy considerations. And then once we have the approval, we can reconstruct in a very private way that only the researchers have access to the actual address. By using scrambled data, we can reconstruct exposures to people's residence without any privacy concerns. Now, if we look at kind of assigning exposures to non-privacy areas such as zip codes and blocks and tracks, then it's not an issue, and we can basically kind of take the unit of measurement or the unit of interest and generate these exposures on a kind of coarse or spatial resolution, and that doesn't involve any PHI concerns.
Thank you. There are a couple questions about concerns about contaminated water, particularly arsenic, and wanted to turn that to you, Itai, to ask whether or not any of the models are using public water testing data and building exposures.
Unfortunately, no. I think water contamination in general, it's a fascinating area, but it's outside the expertise of our group. I think there are people that specialize in this kind of area. We haven't done any, or we haven't used any such information in any of our studies, but definitely something that perhaps we can strive to kind of incorporate in our kind of exposomic view of exposures.
And then a very specific question about which machine learning models do you use most often to predict exposure?
So that's a great question. So we keep exploring new ones, but as I said, each one of these models have their own biases. So we try to ensemble different types of models. So we usually use random forest, neural networks, gradient boosting, but also we've developed a few of these models ourselves. As I mentioned, the Gaussian Markov random field algorithm that we developed, which is a machine learning approach to better predict at very rural areas, which are far away from monitors. We have a series of papers showing the advantage of using that, and that comes in as another kind of component in our larger ensemble models. But we keep exploring new methodologies, new technologies, and yeah, random forest, neural networks, gradient boosting, SVMs, those are the main models that we usually use in our analysis.
Thank you. And there's a lot of interest in the greener platform. Do you want to give a sense of and some some words about how long these types of platforms take to develop and sort of whether or not people are asking if they can access it?
Yeah, so this is only year one of the CTSA funded greener platform. So we're kind of building the backbone and the infrastructure for this. So we have, all our servers, the hardware, the software components. We're currently, I wouldn't say even beta testing, we're alpha testing this quite successfully. The next step for the beta testing will be testing it within Mount Sinai kind of researchers. So we'll have them kind of beta test, and as soon as it's done, then obviously we'll kind of advertise that and open that to the general public. I assume within the year, but with software development, you never know. So hopefully within the next year.
All right, we have a question from, I think, a Bostonian who said they noticed on the slide, one of the Boston images that you showed, the coastal areas on Cape Cod and Nantucket had high levels of pollution. What's the cause of that? Would it be wind blowing from pollution from elsewhere? And then specifically, do you account for wind in your models?
So yes, absolutely. We have 10 or 15 different ways of kind of accounting for wind. I get this question a lot. Yes, this is not a mistake. Initially, when we ran the model, I was sure that we kind of had an error there, but no, this is actually caused by these kind of long range transported polluted systems coming all the way back from Pittsburgh, and because of the geoclimate and geometrology of this area, kind of makes its way all the way to Cape Cod. So this is actually, and the EPMR is actually validate that quite robustly. So this is actually kind of a true phenomenon where at certain times of the year, the Cape Cod area is actually highly polluted because of these long range transported systems.
There is a question about actually indoor air quality, and I'm going to take this one. The question has to do with, it mentions a number of different sources in workplace, or you could imagine them elsewhere: candle burning, perfumes, cleaning products. And specifically, are there agencies that are sort of in charge of improving indoor air quality, specifically at work or elsewhere? And there is OSHA, which in terms of workplace exposures from the work that's being done, there are some standards around that. But by and large, indoor air quality is highly unregulated in our country. But I think that we are potentially on the threshold of a new era. There's actually some proposed legislation at the federal level to start thinking about that a bit more, maybe starting with indoor air quality in school settings. We know that certainly children are one of the most vulnerable populations to contaminated air. So stay tuned for that. And there's another question about the connection between healthcare providers and built environment. And so some of the things that I talked about today, I think the question is related to that. And a lot of the things that I put forward was a visioning exercise in terms of that kind of immediate data being pulled from large data sets or monitoring that's happening. And so I'm sure that there's things in the country that I'm not aware of, but in terms of our work that we're working on, we would love to get there, I'll say. But we're not. We've got a few steps.
So I hate to interrupt, but we are at the point where we need to wrap up. If there are additional questions that were in the chat, we could try to get back to people with some answers on those. This was such an interesting panel. I want to thank our panelists and everyone who joined us today. Our institute is not just doing research, but also working with parents, communities, and leaders to build healthier communities. I encourage all of you to stay connected and help support this critical work. Please fill out the evaluation form. There's a link in the chat. And please get in touch with us if you would like to get more involved. And thank you again to everyone. This was really so interesting.